Okay, we're going to get going now. Leslie will be joining us shortly. She made an introduction, I guess, of me as I was walking in this morning. My name is Lawrence Howard, Larry. I work in the PICU now. I graduated from what was Macon State College, is now Middle Georgia. With my associates, I went to Georgia College and State University for my bachelor's degree, and I am now working on my master's in nursing. I worked in the neuro unit for a number of years prior to going to the PICU. So it was a good change, and if any of you consider fun time, PICU's where you want to be. Come see us. What I'm going to be talking about this afternoon is pain, sedation, and delirium, and briefly touching on neuromuscular blockade management. And this is all pertinent to the ICU settings, which most of you will be in. When I first was doing my practicum as in my associate's program, my preceptor said his favorite patient was one who was sedated, on the vent, and paralyzed. Imagine that. A lot of patient interaction there going on. This looks like a busy chart. We're actually going to break each section of it down. It talks about assessments for pain, agitation, and delirium. And there's a number of things as far as how do you assess for pain. In my world, in the pediatric world, a lot of my kids are babies. So we really can't ask them where it's hurting and how it's hurting. But you look at your patient, and you can assess things like, even if they're like on a ventilator or can't talk to you, things like high heart rates, respiration rates that seem a little elevated, things like this you can look at and assess your patient for pain. There is no point and no reason to have a patient laying in the bed hurting that you have not addressed. So as nurses, always be aware that pain does persist, especially a ventilated patient that's got a pipe sticking down their throat, and they're expected to breathe through that. So this form here, I'm not gonna go through this form its entirety right here. We will break each portion of it down one piece at a time. The form is based on the pain assessment tools. It's called CPOT or CCPOT. It's for critical care pain observation tools. And it relies on things such as facial expression. Are they frowning? Are they crying? Are they just talking? Are they grimacing? Body movements. Are they constantly agitated? Just being very nervous. And you're given different scores, as you can see over on the your right side, different scores, and the total composite score will be a 0 to 8. We're striving, in certain cases, you will never be a 0 or a 1, but as low as possible, as low as reasonable. Somewhere around 2, between 0 and 2, it would be your ideal area. But you look at like muscle tension, if they're on the ventilator, is the ventilator always sounding, going off? Is it?
Would you set a timer for yourself?
Yep.
Okay.
Just, so I have to post it. And I guess, is it still recording?
Oh, yeah. It is.
Okay.
I almost messed it up, but I didn't.
And so if what they call bucking the vent, they're trying to breathe over it, they're coughing on it, you might want to ask yourself, do they need more pain medicine? Is their pain being properly managed? And then check their body movements, muscle tension. Are they squinting their face? Are they grimacing? You might need to adjust their pain. And if any of you have anything to add to this, jump right in, especially you, Leslie.
Well, you guys have already been using that, right? The CPAT?
What we use here a lot of the times is opioids for pain relievers, especially for patients who are on the ventilator or this sort of therapy. And a lot of ones that we use are fentanyl. We use hydrocodone, hydromorphine, which with a lot of surgery patients come back on a dilaudid drip. I have not seen Demerol used that much. A lot of morphine.
They kind of almost took it off the formulary because the metabolites of Demerol kind of kill your kidneys. So they use it in very, very isolated circumstances, but we don't use it for pain a lot.
So these are some things, a lot of things, we'll get some oral ones, which would be like Loratap, Norco, things like that. But when you're using opioids, you gotta be careful and be aware of their side effects, what they can do to your patient. You've got to assess your patient. The side effects, what can it do to your respiratory drive? Anybody? Right. Be aware of that. It can affect your level of consciousness. Your patient may become more somnolent. You're wanting to relieve the effects of pain, but not knock your patient out. There is some people are concerned about using pain medication because, I may become addicted to it. I've had, matter of fact, in the PICU, I've had a patient come back from surgery, and because of the social dynamics of the parents, something in their past, a relative or something, had become addicted to pain medication. Their child has just come back from some abdominal surgery, and the parents, didn't want their child to receive morphine because they might become addicted to it. Not appropriate. If you're cut open, you're going to hurt. Addiction is a real concern, but with properly used pain medications, it's not a problem. And over a long period of time, a patient can become tolerant to pain medication. What's the difference between tolerance and addiction? Anybody?
They require more to take away their pain.
And what is that?
Tolerant.
That is right. And addiction is they feel they need it just
It's
to
a
function.
psychological need.
Right.
There's a test question on your post quiz that has to do with tolerance and addiction. So make sure you read that question very carefully and consider the situation before you just jump to the answer, okay? Because a lot of people miss it, but I really want you to look at the scenario and evaluate it and look at it and think through, because we get a lot of patients on these meds long term. So it has to do with, are they at risk for addiction? So think that through. Think that through. Don't just blurt it out. Think about it.
Yeah. So just be aware as you're using these, because most of you will be using and assessing your patients using these medications. So just be aware of what they cause, what can happen over a long period of time. Another area is of that large form that we have first pulled up on the screen is the agitation scale. We at one time, or still are, we're using the Ramsey scale. The new scale we're going to is called the Richmond scale, or RASS, and it's the Richmond Agitation Sedation scale. And what this does is your patient overly combative? Frequent non-purposeful movements, or patient ventilator dysyncope? Are they fighting the ventilator? Is your patient, how are they acting? And then that's on the plus side, meaning there's not enough sedation on board, and it goes down through 0, -1. They're a bit drowsy. They're not fully alert, but you can wake them up and they can state their names and that sort of thing when directed. all the way down to unarousable. A good brisk sternal rub may not even bring them out of it. That's over sedation. Your patient doesn't need to be over sedated. So we need to strive for a +1 to a -1 on the Richmond agitation scale.
And guys, this is in Larry's lecture because this is already built into Cerner. Ramsey is going away, probably within the next 30 to 60 days. Okay? So this is, in the literature, much more accurate way of assessing and describing someone's level of sedation. And we've had problems with people adjusting pain medication because of agitation or adjusting sedative medications for pain. So they're two different things, and you really got to understand what it is you're treating before you decide which drug you're going to adjust and why. Okay?
And as Leslie mentioned, it is gonna, the old way is going away. We have new order sets that are already in the system, and your doc will print them out and decide, for instance, on the pain. Is the patient going to be on morphine, or are they going to be on fentanyl? And there's different ways based on the, in this case, the Richmond agitation scale for agitation. Different meds, different doses are going to give. Let's see, let me just step back here just slightly. Okay, on here, you can see that the pain scores can be from 0 to 8. Based on your assessment, for instance, you may need to go up. If the CPOP's like this, for instance, you're using a morphine drip, which we are using more and more morphine, and fentanyl used to be the standard. It's kind of getting to be a hand in hand there. Do you see that to be the case, Leslie?
I don't know. What are you guys seeing? You seeing more morphine or just still pretty much fentanyl? Because I was going to say, well, Versat's not for pain.
No.
Versed is your sedating. But your pain medication, we still use a fair amount of fentanyl. But I think the thing, guys, is that there's a lot of titration going on based on what you think rather than per a standard of how. And that's kind of where we're going, is we're going to have a standard.
That's what's being done away, is what you think. Now the standard is, for instance, if your patient's got a CPOT score of 3 to 4, you give them a push Q20 minutes to get that CPOT score into a more like a 1, 0 to a 1. So it's not like, well, I think my patient's in pain, I'm just going to go, jack it up. It's actually going to be on a procedure now. Or if my patient's too much sedated, way down, too low, then there's a procedure for that too. So this, I'm titrating my drips, it's no longer going to be a seat of the pants thing. It's actually in the power orders set, and it's going to be checked by your doc.
This might be a silly question, but I'm seeing a lot of propofol just on its own, not with any pushes or anything. Is that adequate for pain and sedation?
No. Propofol is a sedating drug. And since you brought it up, Rachel, let's go ahead and talk about propofol for a second, because you all need to understand. Propofol is an anesthetic.
There it is.
Okay? There it is. What do we know about Nursing Practice Act and anesthetics? Who can give anesthetic drugs?
You can't push it. You can rub it.
Hang on, I'm going there. You cannot give an anesthetic agent without specific rulings from the Board of Nursing, because that is the purview and the practice of anesthesia prepared providers, namely in the nursing realm, CRNAs, right? Okay, so propofol, and I will actually pull it up and send it to you tonight, has been ruled on by the Georgia Board of Nursing that it can only be given in a critical care setting where a patient is intubated and mechanically ventilated by continuous infusion. You are not allowed to give bolus or push doses of propofol under any circumstances. Clear? So going in there and, oh, my patient's coming out of the bed, let me pop them with a little... No. That is bolusing. Okay? You cannot do that. But the order set that are coming out is you're going to have a backup order for something you can push called Versed. So you can push Versed. So you will have that. So Precedex does not have the same restrictions that Propofol does. So you are going to see, because there's a lot more Precedex being used. And
We
there's
seem to be going more and more as the last few years. It started off a few years ago, where just, odd, but more and more, like in the PICU, almost all of our kids are getting that over some of the other things that used to be used.
They were worried about Precedex for a while because it has a documented side effect of depressing cardiac contractility. So a lot of the cardiac guys and the surgeons, they were kind of hesitant to use it because they didn't want to knock down there. But it's not really a huge, big side effect they found. It's not as prevalent as they thought. So, and Precedex also is coming off of being a brand drug, so it's getting less expensive. So there's a little bit, you're seeing it used a little bit more. So the other problem with propofol is, what's it mixed in? What's it in? It's in lipids.
And what do you think that's a problem for? What do you need to be assessing there to your patients on that?
Every 72 hours. Triglycerides?
Well, yeah, your liver functions, triglycerides, yes, exactly, because it is a fat emulsifier. And so you got to be aware of that.
Guys, have you ever given high dose propofol? Anywhere around that 50 mics?
Never.
What color did your urine turn?
Green.
To blue.
It's blue to green. So if you've got blue-green urine, then that means you've got metabolites from your propofol. It will turn your urine green. So it just depends on how yellow it is underneath it, but it'll turn it blue to green. It's a lovely shade of turquoise.
One reason it's used so much, though, is because it has a very short half-life. It just doesn't, once you shut the drip off, it is moved, your patient burns it off pretty quick, and the effects of it are gone. Whereas if they're like on an Ativan drip or something, you can shut it off and they may be still out of it for 12 hours or so. So it's got a very short half-life. But as Leslie mentioned, in no circumstances are you to ever push the propofol, because it is against your practice. It's against the Georgia Nursing Practice Act and out of our realm of practice.
Guys, the other thing is if you're weaning somebody off the vent, what does the propofol need to be? Off. You cannot take, the patients on propofol have to be on a ventilator in order to give it. That's the Georgia Nurse Practice Act. So if you wean somebody off the vent and the propofol's still there, you're in violation of the Nurse Practice Act. Okay? No propofol for non-ventilated patients.
Except if you're a physician, which we're not.
Well, they can stand there and run it all day long,
Oh, yeah, absolutely.
but they're not going to do that.
No.
Have you ever seen propofol push for nausea?
I haven't.
My girl, she's in. I know somebody at the CRNA school, and that's a common drug is propofol for post-op nausea. I've
Never heard of
pushed-
that.
Why would you want to put somebody out for
No,
nausea?
It's a very low dose that before somebody gets nauseated, they give it to them and it prevents the nausea.
I've not heard of
I've
it.
not heard of that.
Me either.
Like when we take a kid and the doc's going like to IC, not ICU, but to MRI or CT scan, and they're a critical kid and they need to get through that machine fairly quick, they'll go in there and they'll push some propofol. Works like a champ.
By the way,
We
guys,
can't.
before Michael Jackson, propofol was not controlled. It is now.
Milk of amnesia. Good stuff. This is benzodiazepines. This is where you'll find your Valium, your Ativan, your Versed. These are not pain medications, nor should they be. As was kind of inadvertently mentioned, they're in pain, increase their Versed. No. Make sure you know your classes of drugs. Make sure you know what they're used for and for titration. Also, note your reversal agents. One thing about propofol Does it have a reversal agent?
No.
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 Exactly right. That is a problem with it. That's why it's got the restrictions on its use that it does. Your benzodiazepines do, romazicon. So if you've got a patient that's on these drips, be familiar on your benzodiazepine, be familiar with your reversal agents, where they are, and be able to get to them quickly. There's our propofol. We already talked about that. We already touched on Precedex. This is getting more and more used. It doesn't have some of the half-life that your benzodiazepines do. It's shorter. However, it's not as short as propofol, but it doesn't have some of the severe side effects. Leslie mentioned that it was used cautiously with heart patients because of contractility issues, AV blocks, and this sort of thing. Doesn't seem to be as big a problem as they first thought it was. So we're in the PICU world, we're seeing more and more kids where they're coming up, they're agitated and stuff. They'll go ahead and just put them on a Precedex drip, and it works really good for them. This is another flow chart. This is the last section of that first real busy sheet I showed you. This is the confusion assessment method for the ICU, the CAM ICU flow sheet. It is also part of that order set that's going to be in the power orders. This is a way to tell whether your patient is confused. In the adult world, you will see this. In the neuro, I saw it quite often. And when I was a new nurse and I came out of nursing school, I heard about psychosis, sundowners. That's not real.
It's delirium.
It's very real. My father-in-law went in for a fractured hip. I mean, a very intelligent man. And my wife and I were visiting him one afternoon, and the afternoon progressed to evening, and that guy went right out of his mind. He had this case of delirium. And it can be assessed with this assessment method. You're asking questions, having them follow orders, depending on how they do, depends on their level of delirium. And you can follow your power orders and give the appropriate med to that.
Guys, the thing about delirium is that other parts of the country have been addressing this for years, and we've been kind of slow to pick on that, and we basically relegated delirium problems to agitation and treated them with sedation, which just makes the delirium worse. Okay? Delirium is a disorganized thinking and inability to coordinate your thoughts and your actions. That's why I flip back, Larry, to that slide right before this, if you would. You can see that, you're assessing, you're saying, squeeze my hand when I say the letter A, and you don't have to exactly use that pattern. You can just rattle off any old letters, but then when you say A, the response should be that they squeeze your hand. If they can't do that, then their thinking and their organization and their ability to respond to you is not working, and that's delirium. And delirium is different than agitation, and we treat that with different drugs. So a lot of times all these crazy patients that you feel like you can't control unless you sedate the crap out of them really just need a little Geodon.
Or Haldol.
Or Haldol.
And the point being here, this is something now that we as nurses don't really have to say, well, they got a lot of experience as an older nurse. They can really assess this. We've got a flow sheet that's coming to a computer very near you really, really soon.
Yes.
And it'll help you walk through these steps. Is my patient in delirium? Are they just having agitation? What can I do about it? Different meds for different problems. There again, your assessment skills are important to be used here. Paralytics in the ICU. This goes back to the very first thing I talked about when my preceptor said he liked his patients paralyzed. Paralyzation is only used for the most critically ill patients, patients that their oxygen demands are higher than their level of health can deliver, so we're having to paralyze them to take all of the demands except for vital organs down to a minimum, and that's why paralyzation is used. Are you ever to administer a paralytic without ever having been sedated and with pain medicine?
No.
Of course, that does say that, but as it points out there, it's akin to like being buried alive. You're totally aware of what's going on around you. You can't communicate, but you know what's going on. You're hurting just as bad if you were in pain, but you can't do anything about it.
Your patient will call CNN on you because they cannot move, but they're just as awake as you and I are. And there's two, I wanted to throw this out there because I forgot to discuss this with Larry, but you see the picture in the lower corner down there? Have any of you used that? Do you know what that is? Actually it's a biz monitor.
Biz monitor.
That's what you use to
Assess.
the level of paralysis. But this is a biz monitor. The train of 4, which is at the top, that's what you're doing to assess your level of paralysis, or how much is your paralytic drug paralyzing your muscle. The one at the bottom is called a biz monitor. It's a bispectral index, and it is measuring your level of sedation, because if you have someone paralyzed, is your RAS or your Ramsey going to work? No, because they're paralyzed. So it actually measures 2 frontal lobe leads of the EEG and tells you exactly what their sedation level is on a scale, so that you can raise or lower their sedatives based on their biz score rather than your Ramsey or RAS, which is now not working any longer because they're paralyzed. But you do not adjust your paralytic based on a biz, and you do not adjust your sedative based on your train of 4. The train of 4 is for the paralytic, and you're looking for twitches to see how much your paralytic is working. And your biz monitor tells you how sedated. The lower the number, the more sedated they are. The higher the number, the more awake they are. It's on a 0 to 100 scale, with 0 being brain dead and 100 being wide awake. Okay? Most of you in here after lunch are probably about 85. Okay? But don't get those two mixed up. They're measuring 2 different things, but you have to use both on a patient that's paralyzed. Okay? All right, sorry, Larry. I keep interrupting you.
No worries. And in order for your train of 4 to be effective, this is setting up your baseline. You do that prior to administering any paralytics. You've got them on, they're of course on the vent, they're sedated, they've got their pain medicines going. Now you go ahead and you measure their response to the train of 4, and then titrate your paralytic to that. We don't use continuous paralytics in the PICU. Matter of fact, I've only been there for like 4.5 years.
Is that all?
And I've never had a kid on a continuous paralytic as far as for train of 4 and biz and all that. We do use paralytics all the time. For like if a child's really sick and you need to bathe them and turn them and stuff like that, just so they, keep them calm. But you will use it in the adult world quite often, and I remember in neuro we used them. But it's usually for your very, very sick people that are right at it's basically all holds are off when you're putting them on paralytics, because their bodies are requiring more oxygenation than they can get without paralytics.
You got to remember that, guys. Paralytics are to stop oxygen consumption. Okay? So if you can't oxygenate somebody, it stops the muscle movement, it stops the extraneous movement, it stops the consumption of oxygen from skeletal muscles. It stops all that, okay? It does not sedate you. Okay? Paralytics are not sedatives, and sedatives are not paralytics, okay? So if you've just paralyzed somebody, that does not mean you're not just as awake as you and I are sitting in here. That's a bad example right now. But this morning when you all had your coffee, they can be just that awake and just remember that much. And I was really, really proud of one of my new nurses. This was this time last year, I think, that they were having terrible trouble with this patient in CVICU, couldn't oxygenate him. And what do you do when you can't oxygenate? You're thrashing, you're like, oh my God, I gotta breathe, I gotta breathe. And they had to bring this guy down in a hurry, and he was almost coding. And they're like, let's paralyze him. And the nurse said, I'm going to get the set, and she grabbed the sedative at the same time she grabbed the paralytic, and we did get the sedative on board, even in a very tight emergency situation. You just don't do it. You don't not sedate somebody that is being paralyzed. That is been akin to torture. If we're not going to waterboard people, we're definitely not going to paralyze them without sedating them, okay? You just don't want to do that. Okay.
Yeah, we had,
I guess we're gonna take
I'm
off.
reminded of a patient we had, he was ventilated, you know, the full realm of medications were on board, and he self-extubated. Well, the nurse, they got excited and said, we need to go ahead and give him a paralytic. Self-extubated, gave him a paralytic. Guess what we did?
Coded them.
Yep, we were bagging him. We were bagging him because you just knocked out his entire respiratory drive, period. I mean, it's gone. You better be able to replace it. So just realize that if you do give paralytics and use them,
You better have
there are
airway control.
consequences and what can happen. The perils of polypharmacology. And a lot of you guys are going to be working in the adult world and stuff, and a lot of your patients are coming in with a lot of comorbidities, and a lot of docs just throw one med right after the other, and so you'll get a long list of medications being given, some with side effects that you might be seeing, and then they'll throw another medication on board that creates another side effect. Or some patients, for instance, some people go to different pharmacies, which is probably not a good idea because one pharmacy will fill one med with like a generic name, and they'll go to another pharmacy and they'll get another med with the brand name, same med, so they're double dosing. So you, be aware of the perils of multiple medications.
This is all just the end of the class. I need to wait to do those with them until after I
Okay.
go over their other stuff. So
Is there any questions right now on the pain, sedation, delirium, or paralytics that haven't been answered? Of course, we've been kind of talking about it throughout.
I assume there's no reversal or antidote agent to paralytics since you had mentioned.
they have to wear off.
Yep, that's